Hello, hello, hello. This is Truth Be Told. This is Dr. Walter Ock.
And this is Sanaz Saeed.
And we have amazing guest. I've been looking forward to this. I reached out to her. She is the TMJ doc. I've been following her. I think I was referred to you by a friend of my family, my wife's actually. She was like, you need to check this, this doctor out. She's awesome. She really puts out really great content. And anybody that knows me knows that Instagram and Facebook and all, I don't get along. I basically do as little as possible. So when I saw your your page, and I see all this great content, I said, okay, I got to step up my game. But then I said, let me reach out to her so she can explain TMJ. She can explain, because I think that's one part of dentistry that we really don't know much about.
Right.
And so Dr. Priya Mistry, can you please introduce yourself, give us a little history of your background, and then we'll get going.
Hi, everyone. And first off, thank you for having me on here. I'm so excited to be here. So yes, I'm Dr. Priya Mistry. I have been practicing dentistry since 2007. I went to University of the Pacific, which is a great dental school. No complaints there at all. Good school. I was practicing general dentistry for probably 11 years when I met my mentor in 2018. And my mentor was sort of known as like the TMJ guy in Portland.
Okay.
Portland, Oregon. And so I met him sort of on a whim. I walked into his wife's jewelry store and her and I got to chatting, and she told me that her husband takes care of people with TMJ problems. He stopped doing general dentistry like 30 years ago, and he focused his entire practice on TMJ, TMD. And in my head, I was thinking, I see 3, 4, 5 people a year that come into my practice and they can barely open their mouths. They're in so much pain. And I don't really know what to do for them. I don't really fully understand what's going on or what I can do that can help. And so what I would do in those instances is prescribe a mild muscle relaxer, some Advil, some anti-inflammatories. And if they could open big enough, I would try to make them a night guard, like just a flat plane, what we learned in dental school, and
Right.
cross my fingers and hope for the best. But it didn't really help them, is what I was realizing. So I thought, let me just ask this wonderful woman, Dr. Parker's wife. I said, can I contact him? And so long story long, I ended up contacting him and shadowed him. I shadowed him and observed him for probably several weeks. 2 or 3 times I would just go in. Obviously, I mean, I wasn't being paid. I was just trying to figure out what he was doing. I was also on maternity leave.
Okay.
I just had a baby. And so I didn't have another job at that point. So I left my little baby. My father lives with me. So I left the baby with my father and I went and observed Dr. Parker for a few hours, as often as I could get in there. But I knew the first day I started observing him, I was hooked. And I came home and I told my husband, I said, I'm going to buy the practice and this is what I want to do. And my husband thought, oh my gosh, we have a 2-month-old and a 2-year-old. Like, what are you talking about?
Right,
And I just
right.
said, I just love it so much because even that very first day, there were patients he was seeing all day, and they would say, oh my gosh, who are you? Are you taking over? He can't just leave. He can't just retire. He saved my life. Someone told me
Oh,
that. Like, yeah, he's helped me so much, and he has to teach someone what he's doing. So I was already hooked. And so, he mentored me for 3 years. And then I bought the practice in 2021 and I moved it from Portland, Oregon, just across the bridge, 10 miles north to Vancouver, Washington. So different state, but not
okay.
far from Portland, Oregon. So
Right.
here we are. I've moved the practice and I love what I do.
Before we continue, I want to actually hone in on one thing that you said. You actually took the time. You said, hey, I really like this. I'm really excited about something. And what did you do? You took the time to actually get get mentored. You
Yeah.
took the time, I mean, free of charge, right? Because everybody wants to always get paid for something, right?
Yeah.
But
Yeah.
you said, nope, I'm just going to go learn. And that might have been probably the best, I mean, based on what you said, the best decision you could have made.
It is. It is. And once I learned enough, like Dr. Parker was so generous. He actually started paying me a salary, like once I was actually contributing to the practice, right?
Right.
So he was so incredibly generous with
Oh,
me, which helps too, because many of us are saddled with student loans and
yes.
whatever, right? And so he was really very generous and he really felt passionately about wanting to pass his practice on and not just locking the door and walking away, right? And leaving all the patients. Um, so I got lucky, but yeah, I did pursue it as well.
Well, you pursued it. You don't get, I mean, lucky is basically when you have a lot of passion and you
Yeah,
combine that with just
I was about
tenacious.
to say passion.
Right.
You can tell
That's
within.
it.
Yeah.
Here's a question for you. A lot of people don't know a lot about TMJ disorder, right? It's almost like a mystery box that dentists really don't know. We always just say, "What? Your jaw hurts? Let's go ahead and give you a night guard," or "Your jaw hurts? Let's go ahead and send you to oral surgery."
Mhm,
Right?
mhm.
How do you explain to the normal person what TMJ is and how you can contribute to that, to helping them get relief?
Yes, yes. So say you're a patient and I just finished my whole exam with you. I also do a very thorough history. So I want to know about any head, neck, or jaw injuries. I want to know if you had braces. I want to know when this started, how it progressed, any treatment you had. So after we do all that and the full exam, I usually have a pretty good idea of what's going on, whether it's coming from the muscles or the joints or a combination of both, and just sort of how I would treat it. So I always say we talk a lot about TMJ and TMD in my office. And TMJ, it's not a diagnosis. It just means temporomandibular joints, jaw joints. If there's a problem inside of those joints, it will manifest as clicking, popping, or episodes of the jaw kind of locking or getting stuck. Um, and so if the patient has clicking or popping or locking, I explain exactly what's happening with each situation. But if they're mostly there, not for clicking, popping, or locking, if they're there for headaches, jaw pain, neck pain, I say, and then there's TMD, which is temporomandibular disorder. And that's all about the muscles. TMD kind of accepts that there's a group of muscles that work together to guide the jaw in all of its movements. And when those muscles become dysfunctional, they get trapped in a chronic pain and spasm cycle. And it can be very painful. The number one thing it causes is headaches, closely followed by ear-related concerns: ear pain, stuffy ears, dizziness, tinnitus, hearing loss. On to jaw pain, neck pain, shoulder pain, numbness or tingling in the face or even the fingers, tooth pain that hasn't been explained by an infected tooth or anything like that. So I just kind of explain it that way. So it's either coming from the muscles or the joints or some combination of both. And then I explain what we can do to treat it. But I kind of break it down, like where each symptom is coming from. And that seems to be like really, really helpful for people to understand what's happening.
Okay. And so the muscle, which one's harder to treat? The muscle issues, the TMD, or the TMJ, the joint issue? Which one for you is harder to treat for on
The
patients?
joint issue, by far, the joint. The muscles respond. I mean, they
Okay.
hurt a lot. So my mentor would always say the bad news is that it's muscle, but the good news is that it's muscle. The bad news is because it causes so much pain. I mean, debilitating daily headaches, jaw pain, neck pain, but it responds faster to treatment than joint issues. Joint
Okay.
issues can be, they can be pretty tricky.
And which one do you see the most? Joint or muscle or a combination of both?
Combo,
Combo. Okay.
combo, definitely combo.
Okay. See, I think that's important for people to understand that it's not just one or another. Everybody wants it to be black or white, right? And,
Yeah.
and sometimes you gotta say, no, that's not the case.
Right, right. I really see both of them present together a lot.
Do you incorporate the oral surgeon with you with whatever you're doing together?
Yeah, good question. No, I actually don't really. I mean, I have a good high success rate with not having to incorporate anybody else. But if somebody just isn't progressing or I sense that something else is going on, then I talk to the oral surgeon. And that has been very helpful when needed.
So, what are the chances that you can resolve a lot of the patient's issues just with what you do versus going to the oral surgeon to have surgery done or injections or whatever it may
Yeah.
be?
Well, I have a well over 90% success rate. And when
Okay.
I say success, I define it as like no pain at rest in the jaw, no pain with chewing, no pain with yawning, a good healthy range of motion, no more locking or catching, and decreased joint noises. We can't always get rid of a click or pop, but we can decrease it and we can prevent it from progressing to the jaw locking.
So what's your regimen for treatment in TMD?
Yeah, so what I do is I always make TMJ orthotics. And I use the word orthotic because it's different from a night guard and it's different from a splint.
Can you
How
explain
so?
the three?
Yeah, I'll explain the three. So a night guard to me just means it's protecting your teeth. You can get it from the drugstore, you can get it from your dentist, but all it's doing is protecting the teeth. It's not treating the muscles and the joints. That's a night guard. And it has value. I'm not saying it doesn't because we want to protect our teeth. We don't want to break them. Splint is kind of a weird term that I've heard people use for night guard, and I've also heard them use it for orthotic. So I think it's just confusing. So I just throw it in the trash. I don't even use that word because it's just too confusing.
Okay.
And then a TMJ orthotic, that's what I make. So here I have technology and software that measures where the muscles are the most relaxed. It's a specific position called the correct resting length. So it has neuromuscular dentistry roots in like how we're treating. And we use the neuromuscular system, the K7 machine made by Myotronics. I don't know if you're familiar with that, but it's been around since like the 60s. It's good technology, and it really helps us find a good resting position for the jaw. So I do use that a lot, and I do depend on it, but I also tweak what that shows me based off of the condition, the severity of the jaw condition. And so that is like my mentor's spin on it. That's kind of the unique thing that he taught me. So we make these orthotics, a day one and a night one, with the goal of tapering all our patients off the daytime one, usually within 3 or 4 months. The nighttime one, most people choose to wear it indefinitely because it sort of keeps them out of trouble. But in addition to the orthotics, we see our patients every couple of weeks, and we do a very specific, it's called craniofacial therapy, where we really loosen up the muscles in the head, neck, and jaw. So it's like hands-on soft tissue work. So we start at the base of the neck. What was that?
Like physical therapy for them.
Kind of. I mean, I don't want to call it physical therapy because I'm not a physical therapist.
Right, right.
And also physical therapy, also, they usually give you a lot of exercises, and I don't do that.
You don't give them any?
No, I give them one. There's only one exercise, and even then, I only give it at a certain time during treatment. So yeah, we do a lot of the craniofacial therapy. We start at the base of the head, work our way forward. We go in the mouth and release a lot of muscles. We manipulate the jaw in a specific way to help the disc reduce again. And then at the end of all that therapy, that session, we check and adjust the orthotics because they can't change, but we can as patients or as humans, right? And so as the muscles calm down, as the joints start to behave, we have to adjust the orthotics slightly to keep up with the body's changes. Then we send them off and we see them again in 2 or 3 weeks. Eventually things get to the point where they're feeling so much better, they don't have to wear the daytime orthotic. And then, yeah, we just sort of go from there.
So I guess I'm a little confused, and if you can give me a little more detail on that, right? So you do all the I'm going to call it relaxing of the muscle, just for everybody listening. You're trying to relax the muscle. You're trying to get everything back to the normal or more relaxed state, right? The joints, the muscles, and every tendons and all that. How do you know that they're going to keep it there versus, if you don't like give them something to do at home? Like, how do you know that they're not just going to regress back if you don't give them any exercises to do?
Yeah. So, I mean, that's sort of where the orthotics come into play.
Okay.
They're doing like all the work
Okay.
without me having to be there following them around, like relaxing their muscles.
And is it difficult because compliance in dentistry might be the hardest thing, right? You tell a patient to do something and 90% of the time you're fighting against the whole compliance part. So how do you engage them and so that they are very compliant with what you tell them to do?
Wearing it for 24 hours.
Right. And wearing it and so forth. How do you make sure that they're compliant with that?
Well, the nighttime one, everyone's compliant with because they wake up feeling better.
Okay.
So it's like not even a struggle. And that one's like very cushy and very comfortable. And, if you have a daily headache and then you start wearing something at night when you're sleeping and you wake up without that headache, you're going to wear it. So that's like easy. The daytime one, that's the hard one because we do have people take it out when they eat or drink. I don't have them wear it 24/7. We have them take it out when they eat or drink. And then we have some people who graze on food all day. So they just forget to put it back in because they're like having snacks every few hours. We have other people that just forget about it or are very resistant to wearing it because it makes them sound a little slurpy.
Yeah.
Right? Because something's in the mouth. But, I just go back to, you're not going to progress. You're not going to get better if you don't wear it. Okay. And there are some people that actually do get better with just the nighttime one. There are a few people that actually do, right? And so I don't lecture them, but the ones that want to see more progress, I'm like, then you have to make the commitment to wear this. There's only so much I can do. You have to do the protocol or it's not going to work.
Okay.
Do you ever incorporate Botox into your treatment?
Yeah, good question. Very, very rarely. So no, I never start off with Botox. If we're not getting the results that we want, I may bring it up, but I don't like doing Botox in the masseters regularly because sleep apnea and TMJ often come hand in hand. And if we're injecting the masseters every 3 to 4 months, that's going to weaken and atrophy these muscles so much that the jaw can drop back into the airway more. So I don't like to do Botox. And I make that very clear. Like, I think I have like 20 units on hand. It's probably expired and I'm going to throw it away.
Oh.
So I use it, but I use
Right.
it like once or twice a year. And I somehow always end up wasting some because it's just, I don't use it frequently enough.
The reason I asked you to do that was because I wanted to connect that with like, new mothers or like, parents in general. I remember the first year with my first child was just miserable, right? People aren't getting enough sleep. You're stressed. You start to get headaches and so forth. So do you see a lot of that? And is there something that you can teach or talk to about, being new parents, or what we can do to basically bring that down so we don't have to see you? No offense, right?
Yeah, no, that's okay. None
Yeah.
taken. Yeah, I mean, I think that with sleep disruptions and just the increased responsibility, and there with that comes stress of having a life that you're taking care of. I do see it. I do see it with mothers quite a bit, and new mothers also still have those hormones floating around their system, and that can contribute to the TMJ issue being worse for a while. So it's hard. I mean, how do you prevent that, or how do you know who it's going to happen to and who it's not? Right. It's really hard to say. Like, I wish I had a good answer for that. But I would say that if you are having TMJ concerns, to, start looking to see if you have a good local provider. I have a lot of massages and techniques for massaging the muscles. So not exercises, but more massage on my YouTube channel, looking at those and kind of going from there.
My question is you're worried about putting it in the masseter, but what about putting it in the temporalis, or putting it in the neck muscles or the trapezius or anything like that, kind of to help them with their symptoms, not to fix what's going on, but also just to help minimize their symptoms? Do you ever incorporate it in that?
Well, they usually start feeling so much relief with the orthotic that I don't really have to.
Wow.
If they're having like really acute pain, then usually I prescribe like a mild muscle relaxer. And a lot of my patients here are not Botox friendly. I'm in Portland, near Portland. So everyone's kind of it's a different mentality here. It's like everything's natural, and which is fine. Like, I don't feel strongly one way or the other, but I also need to kind of cater to that. But I just don't feel the need that, I mean, if somebody came in here and said, my jaw is hurting so much, just put Botox in it. I want Botox. I'll do it. But I won't keep doing it in the masseter unless they get a sleep study. And I won't keep doing it in the temporalis when I know my orthotic is going to help long term without the injections and Botox.
Go ahead.
I had one more question. Because I'm thinking, like, the way that her approach is on this is so unique in comparison to what I've heard at all these different courses that we've taken, where it's like I took a whole course and they were talking about doing Botox, how you can relieve all this TMJ stuff. Another course I took was with Photona laser. I'm sure you've heard of the Photona lasers. They're saying using Genova lasers can help with TMD, TMJ. Do you incorporate any laser work into or light therapy, anything along that spectrum?
I don't do that, but I do use TENS therapy. So
But break that down. I was about to ask you that question. If you use the TENS.
Yeah, I use the TENS.
Break that down. Explain to anybody who does not know what that is.
Yeah, it stands for transcutaneous electrical nerve stimulation.
Okay.
So it's little neural impulses into the muscles. And what it does is, or electrical impulses into the muscles. And what it does is it really flushes out toxins that have built up in these angry muscles. It brings fresh blood flow. It actually, once you TENS long enough, the muscles sort of relax into their correct resting length. So we use that for 45 minutes to an hour before we record the optimal jaw position. And then some people feel so much relief from the TENS therapy. I had one patient who, she had the TENS therapy, and then she called and said, I don't even think I need the orthotics. I feel so much better just after that. And I just said, well, it's probably not going to last, but let us know what you want. And needless to say, it all slowly crept back. But the TENS was so beneficial that like her neck pain, her jaw pain went away for like 3 weeks to a month. And I mean, that's rare. That doesn't always happen, but like it's pretty powerful stuff.
So let me ask you a question about what causes TMJ, TMD. I know stress. We live a very stressful life nowadays, I feel like. Besides stress, what are the other if you had a list, like maybe 3 or 4.
Oh yeah, I could do that.
Right. What are like some of the other ones besides stress that will cause that? And so maybe our listeners can actually kind of look out for that, or at least calm them, bring that down.
Sure. Well, one thing right away is sleep disordered breathing. So sleep apnea, or its baby sister, upper airway resistance syndrome. If we're struggling for oxygen at night, our body goes into fight or flight mode. We tend to clench and grind with more force, frequency, and longer durations. And when we grind the jaw forward, that opens the airway. So that's sort of like the brain's way of saying, hey, this is how I can improve my oxygen saturation. But then all that clenching and grinding activity leads you to me. So that really goes hand in hand, is sleep disordered breathing, which is a form of stress to the body, right? So,
Right.
that hypermobility. So if you have Ehlers-Danlos syndrome, loosey-goosey connective tissue, hypermobile disorders, that can loosen up the ligaments so that the little disc can slip out of alignment, the jaw locks closed, not fun for anyone. Hormones are a big player in this, beta estradiol and relaxin. So those hormones are found in much higher levels in women as opposed to men. So a lot of my patients are women.
Do you see any post-ortho cases, as we're talking about what can cause these things? What about orthodontics? Are you seeing any post-ortho TMD development?
Yeah, and I'm actually seeing during ortho TMD
Right.
development as well. And so, and that's not anybody's fault. It's just, but there is a connection between like how the teeth fit together, like cogs on a gear, and the two jaw joints. My mentor would always say it's like a tripod-like relationship. And if you start moving the teeth around, it can definitely affect the jaw joints. And how is it going to go? It can be really hard to say, right? And so I have seen people where the disc becomes displaced without reduction during ortho treatment. And then they have to get all their brackets off, get like 7 or 8 months of treatment with me, and then get all their brackets back on. So I've seen that, and I've seen it with Invisalign too. But and post ortho, I've seen it. So yeah, but
going off of the ortho thing, what's the youngest patient that you've seen that has developed something like this, so that they could be on the lookout? Parents can be on the lookout.
8 years old.
8 years old. Wow.
8 years old, and her jaw is locking. She's having pain.
Yeah. And was that more stress related, or because you're going through ortho?
She wasn't going through ortho yet.
Okay.
She wasn't going, but she has a severely retruded mandible.
Okay.
And that's just the way she's developing for whatever reason. And so when the mandible is so far back, it makes it easier for the disc to come out of alignment and become dislocated or displaced.
Can you break down the different bites? Because I went on your page, and I think everybody needs to look you up on Instagram.
Oh, thank you.
YouTube, TMJ Doc. If you go on there, she breaks it down really well. So can you explain the 3 bites and how that could affect or cause TMJ, TMD?
Yeah. So I talk about overbite, overjet, and crossbite. So overbite is, if you look at the bottom front tooth and top front tooth from the side, so coming together, it should be ideally something like this, right? An overbite is when the top teeth go too far down. So an overjet is where they go too far out. Both of these bite patterns make it so that every time the teeth come together, 1,500 times in a day when we swallow alone, clenching, grinding, chewing, every time the teeth come together, the upper teeth kind of make it so that the lower teeth, and therefore the entire jawbone, are held further back from ideal. So when they're held further back from ideal, the muscles don't like that, and the disc can also come out of alignment more easily, leading to clicking, popping, jaw pain, headache, lots of different things. So those 2 bite patterns I see a lot, especially the deep bite. I would say I see that even more than the overjet. And then the 3rd bite pattern I see a lot is a cross bite. So our teeth should fit together like a hat box, with the upper teeth overlapping the lower teeth, kind of all the way around. A cross bite is when it's the opposite. And what that does is when the teeth come together, those 1,500 times a day, clenching, grinding, all that, what that does is it puts too much lateral strain on the joints. And they're just not built for that. These joints are built for a lot of up and down, forward and backward, but they're not, that's not a natural movement. They're not built for that. They don't like that. And then usually something can become displaced, or the muscles can become angry. So those are the bite patterns I see most frequently.
No. When it comes to just overall treatment, do you find that a lot of general dentists don't understand what you do, or a lot of oral surgeons don't understand what you do, or a lot of prosthodontists don't understand what you do. So they're just saying, oh, well, why would you go to a TMJ? And I'm going to call you specialist, knowing that that's not the case, right? But
Yeah.
specialist, somebody that has specialized in this, right? So do you get a lot of, I don't want to call it negative feedback, but in dentistry, not everything is positive, right? Do you have a lot of like pushback from your colleagues?
I don't, because I think my mentor had such a good reputation in the area.
Okay.
Right. I mean, there's always going to be a little bit of pushback, and my social media presence is like large enough now that I've certainly had like trolls come at me or people, but
they exist everywhere.
They exist everywhere. They're always there. And so I feel like luckily I haven't. I mean, I do get some questions like about soft tissue work or manipulation, or is that really valuable? But I have pretty thick skin, and I have, and I just, when I see it work over and over and over again, if someone's questioning me and just doesn't really believe me, I just don't care that much. Like, I know I'm getting the results, right? So yeah. I think my mentor had it a lot harder than I did, because he started doing this work in like the 70s, 80s, when like everything was still, I think dentistry was maybe just a little bit more like stuffy.
Drill and fill.
Yeah. And just like, this is how you do it, like kind of narrow-minded, right?
That's it.
Like my colleagues and my peers that I went to dental school with, they've actually reached out and been like, can you teach us what you're doing? And so rather than kind of being skeptical or negative in any way, people have just wanted to learn, or given me the opportunity to come on podcasts or do a webinar or whatever it may be.
Do you find, do you find, this is a quick follow-up, do you find that, dentist, right, because we don't know much about TMJ, TMD disorder, do you find that we basically send it to the oral surgeon, and an oral surgeon wants to treat it with more surgical base, or an ENT will want to treat it with more, that's ear, nose, and throat doctor, would want to treat it
as invasive?
Say it again?
They're very invasive.
Right. And do you find that to be the case? Like we're treating these patients too invasive, I guess, is where I was kind of wrapping up.
Not anymore.
Okay.
So I have a few friends that are oral surgeons in the area, and one of them actually, before we even became friends, he came and met with me, and he just said, look, like when I see a disc displacement without reduction, I would much rather send them to you than try to do surgery, because surgery is not very successful with that. So he said, is that okay? And I said, yeah. So he's been sending me patients, and they want to see 6 months of like non-surgical treatment. They want to see that the patient tried that before they'll go in. So luckily in my area, like it's not super, like surgery is not pushed for this. ENTs, rather than doing surgery, they'll recommend like going to your dentist and getting a night guard, which is also not a good idea, because that can make the TMJ issue worse, actually. So I wish that more ENTs knew about me, and I'm like trying to get my name out there. But yeah, I haven't gotten a lot of people trying to do surgery, which is good.
You said something that's, you got to expand on that. You said night guards can make the TMJ worse. Break that down, because that's exactly what dentists do. A lot of dentists do.
I know. So please don't. Especially, yeah. So especially if they have those bite patterns, right? So like the overbite, the overjet, the cross bite, all a night guard does, a flat plane night guard, is it takes that bite pattern and just gives them something to grind on. It doesn't break, it doesn't take the bite out of the equation. That's what an orthotic does. An orthotic will actually guide your jaw to a different position while you wear it. So it sort of helps to retrain those muscles to not be in that angry position where the teeth come together all the time. And so a night guard can oftentimes make things worse, because it just accentuates that bite position.
Okay.
Yeah, I see it a lot.
That's it. I'm loving this. What, so I don't know. I know maybe one doctor here in the Houston area that does TMJ, and that's what she does. And I believe she's a prosthodontist that started kind of focusing on that. How do we get our, this kind of information out there, so we have patients, so we can basically help patients? It's almost like a bunch of little islands, right? In Portland, I'm sure you're there, and maybe you might see in San Francisco, and it's scattered. How do we make sure that more doctors, say it again?
We have one in DC, and
Right.
it's
How do
not
we
doing.
make sure that more doctors, more dental students, because a lot of dental students listen to this podcast, how do we make sure that we educate them and show them the benefits of doing these kinds of trainings so that we can provide more to our patients? Because dentistry has become, remember, one thing that I always hate about dentistry is we basically fix, we don't prevent. I'm not sure if you guys
Yeah.
remember when we were going through dental school. So, like, you have a cavity, let's fix it. It wasn't how do we prevent this cavity, you know what I mean? And so how do we educate the future so that they can understand what you do, want to do what you do, so that we can give that option to a lot more patients?
Have you thought about starting a program, a fellowship program?
Yeah, that's a
Yeah,
follow-up.
I've thought about so many things, and my kids are, I just don't have enough time in the day. They're so young still. But what I was thinking of doing for next year, is a series of courses.
Yeah.
So level one will be for any practitioner that wants to know how to diagnose, because diagnosing is not easy. Like, you have to know a lot to diagnose even correctly what's going on with the TMJ condition. So that'll be for like a lot of different types of providers if they want to take it. And then the level two will be like the hands-on treatment that I do, like the therapy that I do. And I want to make that for like a dentist and like physical therapist team that like work together, because I'm a firm believer that the soft tissue needs a lot of help with TMJ conditions. Yeah, I can't just give someone an orthotic and say bye. It's not going to work. There needs to be more. And so I do want to educate people on doing it this way because it works. It works so well. And when people ask me, like, I do Zoom consultations and they'll ask me, who do you know in Maine? I'm like, I don't know anybody there. Like, the few people I would refer to, I have one in Miami Beach, one in Kansas City, Missouri, and one in St. Paul, Minnesota.
That's it.
That's it.
That's it.
That's it. I don't know anybody else that treats disc displacement without reduction successfully over and over and over again. I just don't, besides those people.
Maybe you can start like a Facebook group so that people can connect. Because I mean, this
Yeah,
is a lot. A lot of patients come for this.
yeah, yeah, yeah. I
And we're
mean,
just with symptoms. We're not treating the main cause. We're just
yeah.
treating symptoms.
And well, the tricky part here is that what is the main cause? Because other causes it can be coming from the cervical spine.
Mm.
It can be coming from the hips. It can be, so I just named stuff that like we can clearly recognize, like hypermobility or a bite pattern or sleep disordered breathing that can be diagnosed. But like, it's really tricky. Like, it can be a whole body issue for some people, and for other people, it can be coming only from their bite. So that's what's kind of tricky is I'm trying to think of a way to create some courses, and I've got some ideas floating around in my head, but like the end of this year is when I'm really going to get them down on paper, get it outlined, and then just start shooting videos and doing it, because I think the information needs to get out. It's important.
So do you refer patients to a chiropractor, a massage therapist, or a physical therapist?
So we do a lot of like massage and soft tissue work. So I don't usually refer to massage or physical therapy.
Okay.
I have a massage therapist who is also a dental hygienist that works with me. So
Okay.
she's like my other provider in terms of doing like the therapy treatment that we do.
Right.
There are chiropractors that I refer to, but I only utilize the skills of upper cervical chiropractors. These are chiropractors that do not do any pop, twist, or crack. I'm not sending you somewhere where you're going to get your neck cracked at all. So
Hmm.
these people, the upper cervical chiropractors, and they have their own like differentiations. But to put it in a nutshell, they take a series of diagnostic X-rays of the upper cervical spine, and they tell you if like C1, 2, 3 have these like rotations or lateral shifts or misalignments or they're tilted, because that can feed up and affect the jaw. So if I'm treating someone for a while and they're not making progress, it's usually because of their neck. And I have a few people I work very closely with. Um, and I mean, there's probably a handful of people just recently that have gotten so much better since getting their necks taken care of, because it feeds up and affects the jaw. They're right next to each other. It
Right.
makes sense. So my mentor discovered that connection, though. I mean, I can't take credit for any of this. He learned all this before Google. So he actually traveled the world and he worked with osteopaths and chiropractors and naturopaths and orthodontists. And I mean, you name it, he worked with them. And then he brought everything he learned and put it together.
Speaking of naturopaths, and a holistic approach, being especially where you are on the West Coast, where holistics is so a major component, and there's a market for it.
Mhm.
Are you referring for anybody for acupuncture with the naturopaths? Are you referring anybody for dry needling with the naturopaths, or anything along that spectrum?
Sometimes acupuncture, but I just feel like I don't know enough about dry needling. Like I need to learn more about it before I feel comfortable referring. But that's not to say anything negative about it. I just actually don't know much about it. But I do
You
sometimes.
acupuncture.
Sorry, go ahead.
How often are you referring for acupuncture?
Oh, not often. It's like maybe a few times a year because usually we just don't need to.
Okay, so I'm going to ask I'm going to ask I guess somewhat personal question, right? Anytime you're doing anything like this, anytime you are kind of setting the path, well, your mentor set the path, you just
Yeah,
followed the path, right?
I did.
When you're doing that, you know, a lot of people are like, man, it's going to be a hard grind. You opened your practice on the opposite side of where he was, right? And so you had to build the patient pool. And I think we're in a world right now where people are not patient. So how long did it take you to get going when it came to like patients coming to you, and how do patients find you?
Yeah. So, I got really lucky because what happened was obviously COVID happened and none of us were lucky that that happened. But what it did is it got us all thinking like, oh gosh, like we just came up with this purchase agreement. I'm going to buy the practice in a year. Dr. Parker was kind of panicking. My mentor, he was like, what if the practice sinks and I don't get to sell it? And I'm thinking, what if it sinks and I don't get to buy it? So we're all kind of panicking. So he said, come up with an idea. He said, everybody come up with a few ideas of how we can keep afloat. So people had ideas like Google ads and Facebook ads. And Dr. Parker wrote a book about TMJ, a little booklet that we sell. And then I couldn't think of anything. So I just said, I'm going to start a YouTube channel. And he just looked at me like, okay, like he was skeptical, but I really couldn't think of anything. I like to talk. I like to share information. I like to teach. So I started it sort of on a whim in August of 2020. Fast forward to now, we have like 33,000 subscribers, which isn't a lot, but it's also not a small amount.
Yeah.
And because of the YouTube and Instagram, I think I have close to 60,000 on Instagram. That really took off for whatever reason. That's actually really helped the practice. Like people find us. I have people traveling from like the UK, from Guam, from Toronto, from Boston, from Jersey, from Louisiana, from California, of course, Canada, like tons of places to come see me because they found me on YouTube or Reddit. I didn't even know what Reddit was, but someone put my YouTube videos on Reddit, right? And so social media has been huge for my practice. And I didn't even go into it with that intention. Like I just thought, okay, maybe someone will see a video and come in and that'll get us one new patient. That like I just didn't see how much it could do, right? So I feel like that's what really helped. But Dr. Parker has a broad referral pool. And even though we moved, there's really not a lot of other places they can go.
Okay.
And we only moved 10 miles.
Right. Okay. Sometimes that's a lot. Some patients are like, it's too far. And you're just like, you can see my office.
Yeah. For some people, that is a lot. You're absolutely right.
Yeah.
But Walter, these patients are coming from international because they're in pain.
That's awesome.
It's late at night, it's early morning, they're in pain. I'm one of those people that's done that. And I go on Instagram and I type in hashtag, outbreak of skin. They might be putting like hashtag TMJ pain.
Right.
And then so they're traveling everywhere because they're in pain. 10 miles minus isn't gonna matter to them.
For sure. For sure. So one question. When it comes to foods to avoid, you had mentioned that, and that was something that kind of caught my interest. Food to avoid. Can you go over if somebody's having TMJ, TMD issues? Can you tell us some of the foods to avoid and some of the habits to avoid?
Yes. So definitely no like chewing on pens or chewing ice, chewing gum. No. Also foods to avoid, I would say anything like tough or chewy, glutinous, like bagels, really not a good idea. Beef jerky, steak, raw carrots, raw apples, salad can be really difficult to chew. It just takes a lot of chewing activity. So sticking to a soft food diet, at least, for the short term till things calm down a bit, I think is a good idea. But those tough, hard to chew foods are good to avoid.
Well, I really appreciate you ladies taking the time to come on. I mean, I can't thank you enough. I really can't with the time. I know how busy you guys are.
Well, thank you.